Nothing to disclose. Thank you very much for inviting me to talk about this zebra. This is not a very common scenario, very thankfully that it is not a common scenario, but I'm excited to talk about it nonetheless. Post-hepatectomy bile duct stricture, etiology, presentation, diagnosis, and management. Again, it's very much a relatively rare entity outside of a stricture of a HJ or a stricture of a bile duct from a biliary injury during cholecystectomy. So, again, back in 1999, the Cleveland series only had a 4% incidence. If it presents late, it's usually weeks or months to years post-surgery, secondary likely to ischemia. If it presents early, it's most likely a technical iatrogenic injury during transection of the biliary tree near the hilum. Why do I say it's so rare? In 2019, somebody got an abstract published reporting 2 cases. That was like 3 years ago. Okay, that's why it's rare. So the one case was a 79-year-old man who was undergoing a right hepatectomy for a colorectal liver metastases. This patient presented in post-operative day 7, so very, very early post-operatively. Progressive jaundice, left-sided biliary stricture that was managed by ERCP and stenting. Another patient, 57, right hepatectomy for liver metastases. This patient presented 21 months post-operatively. And this was secondary most likely to ischemia, and it was a benign etiology and then also managed with ERCP. So from a technical perspective, in the hilum, and you can speak to different surgeons in terms of how they manage dividing the biliary tree, especially when the tumor is very close to the bifurcation, how they protect the contralateral side. So people will say they'll protect it with a vessel loop, a umbilical tape, or a silk tie. I've progressively moved towards the silk tie because if that gets caught in your stapler, there's no consequences. Umbilical tape, there's a count issue, and obviously a vessel loop is a problem. So these are the most common etiologies: bile leak, ischemia, scar, disease recurrence for the oncologic etiologies of doing this operation, and then really the stapler device is a common etiology for this very rare situation. More and more we're hearing about ALPS. There was a early series reported in 2017, 5 years, 500 conventional liver sections, 28 ALPS. The post-operative biliary stricture rate for the conventional liver resections was 1.4%, very low, versus 10.7%. And they were at the level of the hilum at the left hepatic duct. This was the most common scenario. How do patients present? Jaundice, elevated alkaline phosphatase and bilirubin, occult imaging findings. So you're doing follow-up for a patient, you are doing their surveillance imaging, and it's their 3-month scan, and you see progressive biliary ductal dilatation. No symptoms, no cholangitis. And then certainly cholangitis is another manifestation of this presentation. So 10 years in practice, that's how long I've been in practice, 10 years. Many people in the audience here have been there longer. And so I was looking through, thinking about patients that have endured this problem. And I have one, and maybe that's the denominator, but one. And this was not a lobectomy. This was a 59-year-old woman who had synchronous metastases for sigmoid colon cancer. She had 2 lesions, and she underwent a little bit of neoadjuvant chemotherapy because she had multifocal disease, and this was her tumor. And intraoperatively, I did notice a little bit of bile, and I think it was secondary to a thermal injury from the ligature. I think that this is what happened to her. And so we repaired it, but we also left a drain. And she had the drain for a few weeks postoperatively, and then ultimately had the drain removed, but this is what her scan looks like now. So this was now 5 months postoperatively. Asymptomatic, no cholangitis. Do you take this patient back to the operating room? Do you put them through an ERCP? Do you make them get a PTC? And so how do you decide that? So one easy thing is look at their blood work. Look at what they look like. In February of this year, her bilirubin's 0.5, her alkaline phosphatase is 275, getting close to normal. I have done nothing to her or for her. I think the instrumentation in someone like her who had multifocal disease will seed her biliary tree. When she recurs and we have to ablate her recurrence or take her back to the operating room, it increases her risk of intrahepatic abscesses. So for her, I'm going to do nothing. Any dissenters to that? No one, okay. So how do you diagnose it? Cross-sectional imaging, CT, MRCP, and then anything you do to a patient, do for them or to them, it's progressively more invasive. So certainly cross-sectional imaging, least invasive, CT, less invasive than MRI in terms of the time and duration the patient has to endure being in that machine, ERCP, PTC surgery, and we saw that repeated today. If they can manage balloon dilating it from below, that's pretty minimally offensive. If they cannot, then PTC, and we saw that scenario in the previous speakers. And then surgical revision. So that scenario is in our venue is dealing with this. So I had to go back in the literature. I had to PubMed, and I had to go way back to see there was a paper that covered this very, very narrow specific topic. So Jeffrey Matthews, you may have heard of him. Leslie Bloomgart, may have heard of him. 1991. I know for some people that's not that long ago, but some people it is a little bit long ago. I think I was in high school. Yeah, I think I was in high school. Picture it, Bern, Switzerland, 3 patients. They reported on 3 patients in their study. And so some of the technical considerations that they commented on, because really it was just a case series. One, after a right hepatectomy, you have markedly increased left-sided hypertrophy. So the anatomy is twisted this way, such that the hilum is now more posterior and a little bit more superior. So access is a little bit more challenging, and your normal anatomic approach, you have to kind of adjust for that difference. And there are really kind of 2 different approaches to addressing a post-hepatectomy stricture. One, you can go for it. You can go right to the hilum. And then the other way to go about it is just to the left of the ligamentum teres. If you get into that space after you divide this little bridge of liver between segments 4, 2, and 3, you have exposure of your ligamentum teres, and then you have access to the segment 3 bile duct. You make your ductotomy, you can do a hepatocogegenostomy. This was in fashion before all the percutaneous approaches for palliative bypasses, palliative biliary bypasses. But if you have a hilum that is highly unfriendly, then this may be a much safer route to get to where you need to be. Thank you.